Hello and welcome to the HSJ Health Check Podcast. My name's Ben Clover and I'm a Bureau Chief at the Health Service Journal. For this week's podcast, I'm joined by three of my colleagues, Nick Carding, Jasmine Rapson and Mr. Jack Serle, who are going to address three of the issues that I think are of significant interest at this point in the NHS and indeed the country's struggle against COVID-19. As we record this podcast on Thursday afternoon, the government seems poised to relax a number of the lockdown restrictions, with an announcement expected on Sunday. So we thought it was an appropriate moment to look at both how the service has done and look a little way into the future on the testing and tracking programs and the tracing programs. But first off, we're going to speak to Jack Serle, who's one of our reporters who's been covering the mortality rates, particularly to give us a picture of where we are at the moment. So, Jack, where are we on mortality at the moment from COVID-19?
Well, deaths in hospital from COVID are kind of falling across all the NHS regions, which is very encouraging, obviously. From a kind of mid to early April peak, which seems to fall just before the Easter bank holiday. Bearing in mind that there is sort of several kind of delay factors that we need to count in. One is that the 5 most recent days worth of data that comes from NHS England is less robust than the rest, and that's to do with delays with the reporting and confirmation of people's deaths. And then there's also other factors like the way that the disease progresses in people. There's a delay from starting to show symptoms to deteriorating to the point where they need to go to hospital, and then there's a subsequent sort of delay once they're admitted, and then they get into ICU and then either recover or sadly die. There's a sort of a period there. So what we're seeing now is the certainly in London and in the Midlands is a fairly kind of dramatic decline in the total number of deaths reported each day. Which I think is definitely going to be to do with the social distancing policies that we all started to enact, that were implemented, and we all started to do, closing pubs and restaurants, keeping a distance from people, all of those sorts of things, because fewer and fewer people were infected with the disease, fewer and fewer people required hospitalization, and fewer people have sadly died. Deaths are going to continue, obviously, for the foreseeable future as transmission continues in the community, and therefore people will still follow that progression. But happily, certainly in those areas that were the hotspots last month, the West Midlands, Birmingham and the Black Country, and London, numbers of deaths, numbers of cases, and numbers of hospitalizations are falling.
Gotcha. So the overall picture is London appears to be past its peak. That is a fair decline from early April. I mean, although obviously it's worth pointing out the numbers are still very high compared to normal. You mentioned the other regions. So sort of the worst affected regions are obviously, like you said, the metropolitan ones. But are we seeing a plateau or a decline there?
So the starting with the southwest, which has been the least affected in terms of hospital deaths out of all of the regions, and finding out why will be particularly interesting, I think, as time goes on, is a very slow and very sort of shallow increase, or very low peak, and a slow decrease as well, and that's sort of replicated elsewhere. So other regions that showed very sort of pronounced exponential or very steep growth, like London, seem to be falling off rather more quickly. The north is an interesting component in this. Northwest and then northeastern Yorkshire are still reporting obviously far fewer deaths than they were during the peak in mid-April, but more than there are in London, more than there are in the Midlands, and that's I think notable. Northeastern Yorkshire, the cases and deaths seem to be certainly historically were clustered around the kind of urban areas in Tyne Wear, and Teesside, not Teesside, sorry. So around Gateshead, Sunderland, that kind of that part of the northeast coast. And that particular region seems to be flattening out. There's been a couple of days in recent past where the number of deaths has been broadly sort of stable, reported each day, which doesn't looks like that's not going to last, and the figures will continue to decline. But it's notable, and there may well be some more research will be needed to figure that one out as to why.
Gotcha. So on kind of daily reporting, London's now outstripped by most of the other regions, but everything is coming down except the northeast.
Yeah, but the northeast is also below its peak. I think it's not that it's plateaued. It's just, as you can see, this sort of declining gradient. It's taken a turn that's not reflected elsewhere.
Did the northeast start later than the others in terms of having the higher numbers of deaths that were seen elsewhere? Maybe is that one factor, or did the number of deaths rising happen at the same time as elsewhere?
It was later, and that may well be a factor. And it's so the chief exec of the London Nightingale Hospital a week or two ago spoke on a webinar and said that the trajectories, the sort of progressions of cases and hospitalizations and deaths in London, to his mind, shows good compliance with social distancing policies, and that's why we're seeing such a stark fall off in deaths. It's why it's such a steep decline, as we all move to cut community transmission. That has had a knock-on effect, and so the peak of deaths reflected peak of community transmission a fortnight or 3 weeks sort of before that point. Crudely put, I hasten to add. But I'm sure there's going to be other factors as well that determine a more shallow decline in other parts of the country, maybe to do with the relative age of the affected populations, and so therefore you're seeing more older people in other parts of the country who, as we know, have less good outcomes than younger people. I'm sure it's not just that Londoners were better at social isolation, though given how stroppy Londoners are, and I speak as a Londoner, born and largely born and bred, there may well be something to do with that. It may well also be that things like the London Underground and buses was such a strong factor in driving community transmission, which aren't necessarily as all-consuming for commuters in other metropolitan areas, mean that as soon as we all got off the tubes and got off the buses, that dramatically slashed transmission in and of itself. But this is interesting speculation, and more work will need to be done to find out why. But I would steer clear from suggesting that the people of Manchester and the northeast are more gregarious and therefore less good at abiding by social isolation rules. I think it's more complicated than that.
Fair enough. And just quickly, like Nick, you cover a bit of the southwest. Well, like most of the southwest. Is there anything like even anecdotal people say about it? Is it just that it's less dense, the population down there? Because it is a fairly older population, isn't it?
Yeah, I think some people are almost a little bit surprised at how little affected, again, in terms of hospital deaths, the southwest have been. I have spoken to a couple of GPs who say they have seen quite high numbers of sort of deaths in the community. So maybe that's where the real story in the southwest is being told, in that there are more people dying in care homes or at home than there are in hospitals. And that may be as a partly result of the rurality of where people are living. It's harder for them to get to hospital, or they don't necessarily go. So that again might be a story that is told a bit later on as we get more data on figures, I suspect. So I don't think the southwest has escaped as easily as it may look on paper.
No, fair enough. And that does bring us to I was going to ask Jack about like care home settings. Obviously, when they first started reporting data, it was mainly just the hospital deaths that people focused on, and care home deaths has now got a bit more attention. Can you tell us a bit about the trends in care home deaths?
Yeah, so the Office for National Statistics, as I'm sure everybody is now aware, given the amount of publicity their data publication has received, are producing statistics on deaths in all settings, not just in hospitals, but also in care homes, hospices, people's private homes. There is a lag on that. So the most recent figures from ONS show deaths that occurred up until the 24th of April and deaths that were registered up until the 2nd of May. So there's a sort of slight double delay factor there, because obviously when registering a death may take some time, given the intricacies of that process in some instances, and where there may be confounding or complicating factors that delay that process. But caveats aside, it's clear that deaths in non-hospital settings have increased markedly, and certainly in the sort of period about a couple of weeks ago, in that mid-April period, they went up quite dramatically across England. It's going to be interesting to see how that data progresses as more of it comes out from the ONS, because it's lagging so far behind where NHS England's hospital deaths data is. It's really showing. It seems to me it's really showing the peak of the epidemic and its impact on fatalities. Whether it's going to plateau and it's going to show that the care home deaths emulate those in hospitals, and there is a peak in mid-April and then a decline. We'll have to wait and see. I mean, it's confounded slightly by considering the settings that we're talking about here. I mean, if we're talking about deaths in hospital for people who are going to be, who are not going to be in that over 70, over 75 category age population who are in care homes, there may be more likely to be people in the sort of general populace. They're talking about community transmission. This is people getting it from going to the supermarket or seeing friends or what have you. Therefore, social distancing policies are going to bite more quickly for that sort of transmission versus transmission in an enclosed community like a care home or something, where, as we know, infection control can be quite difficult at the best of times. So whether the measures that have caused the peak in hospital deaths and in hospitalizations to occur in around just before the Easter bank holiday, whether that's reflected in care homes, I'm not so sure. I would expect it perhaps to continue beyond that and to peak later, just because it's more difficult and because control measures were perhaps implemented more systematically later than they were in the wider community.
That's interesting. So we don't know really where the peak is yet. Although measures that have been taken recently include, like Nick, kind of the government's recently announced not mandatory, but kind of tests for everyone 65 plus recently.
If you have symptoms, yes, it's.
If you have symptoms, okay. I should say Nick is one of our technology reporters and has been looking at the testing front, which is another front the government's been fighting on. It's attracted a lot of attention. Like where are we up to on testing, Nick?
Yeah, there's been a lot about testing in the news, which I'm sure most people have heard about. So, quick recap. Clearly, in April, so last week, we were approaching the end of the need to get to 100,000 tests a day, as per the target set by Matt Hancock. As we reported on Friday, there was a massive drive to increase the number to get the government over that 100,000 line, and that included making the decision to count tests that were being posted, so tests that hadn't yet been processed but were just being delivered to people, even though not all of those tests would be then returned. So that helped the government to get to 100,000, but that was only for a day or two, and then now 7 days into May, in 5 or 6 of those days, the number of tests carried out has gone down, and we're now, as of I think yesterday or the day before, they carried out 69,000 tests. So quite a steep decline, really, and not really very good news for Hancock and his 100,000 target. And then, of course, yesterday we then were given news of another ambition, which is the word that Boris Johnson used, not target, but ambition. And he said that the ambition is to achieve 200,000 tests a day by the end of May. But it subsequently emerged that he was talking about having the capacity to carry out tests, not actually processing or even posting them, but just having the capacity. And currently the capacity to carry out tests is at around, I think, about 120,000. And I think it'll be a lot easier for the government to hit the 200,000 target than it was to hit the 100,000.
Righto. So having only really hit the 100,000 target through changing the terms under which it's considered, the government has doubled the target but slackened off the criteria by declaring it an ambition. And by saying this measure also will not include actual tests done, it will just include having the capacity to do that. Is there? Can you tell us like who is being tested at the moment, and what the utility of this is? Because as I understand it from like the way South Korea did it was on a much bigger scale, much earlier as part of a containment strategy. So who are we testing now, and why?
So broadly, we're testing obviously patients at hospitals. We're testing staff, NHS staff, and care home staff, care home patients. We're testing key workers and their families, and we are also testing, as you say, over 65s and certain other workers exhibiting symptoms. Because we have got much more capacity than more than there actually is a need at the moment. The government yesterday said that they were going to extend testing on a weekly basis for NHS staff and patients, and also care home staff and patients. So that will probably help bridge the gap between supply and demand. So that capacity is going to start to get used a lot more now that there'll be weekly tests available for NHS patients and staff and care home patients and staff. So that's quite a significant move, I think, and that will also help to track the infection in those settings much better. And then the other bit that we haven't yet talked about is there'll be, I think, much more scaling up of the commercial sites. So the drive-through centres, there's still a few more sites to open there, and also the development of the antibody tests, which might come along sort of later on this month. And then finally, we're also hoping to see a bit more about the sort of surveillance randomised population testing, which is under Pillar 4 of Matt Hancock's testing strategy. So I think May will be quite a important month for working out how exactly the government uses its testing capacity.
And tell me if I understood, sorry, the government has made a commitment for weekly tests for NHS staff and care home staff.
Yeah.
Right, because I mean, obviously that's something that care home staff, one of a couple of things that care home staff complained bitterly about much earlier in the process is not having, as well as not having PPE, not having testing to know who was potentially infecting their colleagues and the people that lived in the care homes. So in a way, that sounds like that's going to be the much more consequential measure of performance rather than what the capacity is. It's kind of how that capacity is wielded to try and protect staff as much as possible. You mentioned the antibody test. Can you put me in a picture just about like what those are for and why they're important?
So the antibody tests are the tests that are supposed to show us if we've had COVID-19, and the reason they are likely to be important is because if we are known to have had it, there is also a strong chance that we may well be immune to it, and so that will open up, opportunities for people to say that they are immune and are therefore safe to, whether it's go to work or visit family or have all the luxuries, if you like, that we currently can't have because of the lockdown situation. So it'll be very interesting to see when the antibody tests do arrive. Currently, no test has been proven to be 100% accurate yet, so that's why we haven't had them yet. But when they do start to arrive, it will be really interesting to see how the government decides to use the information that we get from those tests, because there are some quite strong concerns from SAGE, the committee that advises the government on potential abuses of the systems. So people, for example, deliberately trying to get COVID-19 in order to get immunity to then go back to work quicker than they otherwise would have done, or fake tests appearing, which sort of to say that you are immune when you're actually not. There are also ways in which the system can be abused, and you've got to be quite careful before you sort of follow the information of those tests and base kind of your social policy on what happens next.
That's interesting. I guess like an advantage, particularly for people running healthcare organisations, that once this antibody test does arrive, and if it turns out you do have immunity once you've had it and you can prove it, you can start deploying those staff, I guess, without the PPE. Kind of, you could actually have wards staffed by people who weren't in danger.
I presume that's an opportunity. Yeah, without knowing the science completely inside out. But I guess it's certainly probably a way of optimizing where the PPE goes. Yeah, to make sure that it only goes to people who are the most at risk.
That might be a while off. And is it something that we're definitely going to have? Like, it's not here yet, but it seems like something. There's no doubt that it's coming.
It's definitely, it's certainly a very strong aspiration. And when you hear the testing leaders talking about it, they talk about when it comes, not if it comes, although they are clear that it may well not be for a few more weeks, maybe even a few months. You never know. But back at last month, John Newton, the testing chief, was saying that antibodies will start to become really a hot topic in sort of May, because that's when they'll be needed, because then people will hopefully have had it by then, so that's when they're kind of the most useful. So I would expect antibody tests to really kind of be just to be scaled up if they can find one that works sort of by the end of this month or into June.
That's interesting, and it's that's one of the big fronts for how the NHS is looking to protect its staff and also the population. But kind of another one that's maybe developing, has also been much talked about the last couple of days. Jasmine, you've been looking at the tracing app, and just to assume zero knowledge on my part, this is technology that's intended to allow kind of people in public health to go, well, I'm infected. Here are all the other people that might be at risk as a result of that. I mean, that's what it's for, right?
Essentially, yeah. So there's been kind of quite a lot of discussion around these plans since they came to light a good few weeks ago now. And the idea is that as many people as possible will download this contact tracing app. And then the idea of it is kind of Bluetooth signals between people's phones will talk to each other. And if someone starts displaying symptoms of coronavirus, they will tell the app that they have symptoms of coronavirus. And then anyone else that they've been in close proximity with will get an alert on their phone, which will basically tell them to self-isolate because they've been near or in close proximity with someone who has coronavirus. And it's at the point now where it's being trialled on the Isle of Wight. So it was launched on the island this week. So there's still not loads of information as to how that trial is going. So it will be interesting to see how that works out. But obviously, there is still kind of quite a few concerns about how the privacy will work, particularly as NHSX, which is the organisation that's kind of working on this, has developed it kind of so quickly. Usually these technologies could take years to produce and launch in the country, and now they've had to kind of basically get something together in a matter of weeks. So it's definitely been a very big project for them, and I'm sure they will encounter many problems along the way.
Gotcha. And you mentioned the privacy concerns, and there's something specific about NHSX's system on the app that's a concern to people, right? What is that?
Yeah, so NHSX had the opportunity to take on a decentralized approach, which is what was supported by Apple and Google. And this basically means that all the information is stored in the app on the user's phone. And it's argued that that is a kind of more secure approach because all the data and information is just kept in one place and there's no real well, potentially no real risk that this could, anything untoward could be done with that data, or it could be kind of, sent elsewhere. Now, NHSX has basically initially rejected that idea and said, no, we're going to do it all centrally. So, some of the information at least is stored in the NHS. And their argument for doing that was because it would mean that they're more able to track coronavirus, which does make sense. And then they could use that information to build on and develop the app. So that's the kind of route that they've gone down, the path that they've gone down. There are reports that have kind of come to surface this morning, which suggests that actually the NHS hasn't kind of closed all the doors on Google and Apple, and kind of a matter of days into the trial, they're potentially looking into going back to the decentralized approach. But we'll have to see what happens there. That's not 100% confirmed yet.
I mean, that would be a bit of an embarrassing U-turn, wouldn't it? I'd have thought, because they've sort of spent, having seen some of the government committee hearings, they've sort of spent the last 2 weeks defending why they're doing that centralised approach, haven't they? Yeah,
it'd be very embarrassing for them. And I think there's been kind of still some confusion as to why they've gone down that approach, because it seems like other countries in the world are kind of, looking at the approach supported by Apple and Google. So it doesn't 100% make sense why they've decided to kind of go down the route that is suggested to be less secure, particularly as there's so much public concern around privacy and the sharing of their data as it is anyway, and they want to get as many people to download it as possible, otherwise it won't be as effective. So I mean, it'll be interesting to see where they go with that, and I guess maybe we'll find out more within the next week or so, once the trial on the Isle of Wight is over and we get more of an idea as to what they're going to do in a national sense. But yeah, it's certainly interesting, and it's a big learning curve for them as well, because they haven't done anything like this before. And Matthew Gold, the chief executive of NHSX, has said himself that it won't be perfect when it's launched, and there is a lot of work that needs to be done on it. And the more people that download it, the more kind of the more they can improve it, and the more they can make sure it's an effective piece of technology. But I mean, the idea at the moment is just, well, hopefully for them to prevent another kind of coronavirus peak with this technology. But there's definitely a lot of work to be done.
Gotcha. And sorry, just to go back for a second, the argument for centralizing this data, i.e., say you get a match, say I'm infected, and then I tell it I'm infected. It goes down a list of all the contacts I've had, and then alerts them. Kind of the centralized thing is that the NHSX has that data and can then say, oh, there's a spike in Solihull or wherever I am.
Yeah, that's my understanding of it. I'm not kind of fully aware of the finer details, but they've senior people in NHSX, they've said the whole reason and purpose for launching this app is to get more of a hold on coronavirus and where it might be spreading, and to try and kind of, I guess, gain control of that as much as possible. There was a story that we published this week, senior sources are basically saying, while NHSX has insisted that people won't be tracked, their locations won't be tracked, there's still some concern that once a person logs that they have symptoms, that they are then traceable, and there's just a bit of kind of confusion over what could then be done with that data.
So is there any sense yet, because this is supposed to scale nationally in 2 to 3 weeks?
And it's quite vague at the moment, but they want to do it as quickly as possible, because I mean, especially as they're saying that we could potentially lift some lockdown measures within the next few days, so they want to try and get this rolled out as quickly as possible for when lockdown does lift.
Gotcha. So it sounds like there's a bit of a PR battle to be fought to persuade people that their privacy is not going to be invaded.
Yeah.
Or if it is, that's a fair price to pay for avoiding a second peak. Okay, well look, that's interesting. Thanks all of you for taking the time to inform our listeners to this. We are back next week, so do please, if you enjoyed the podcast, do please let other people know about it. It's available in all the places you can normally get podcasts, and also HSJ's online coverage Our unrivaled online coverage of the COVID-19 crisis is all free to access on our website, so do check that out as well. Do email us if you've got any hot tips on exclusive stories we should be breaking. All of our details are on the website. And thanks very much for listening. We'll see you another time. Thank you. Bye-bye.